Good afternoon, delegates and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar on sexual desire disorder. And today's icon is Dr. Anita Shyam ma'am. So before introducing ma'am, let me introduce Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is a consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also an infertility specialist. Ma'am is also part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am, and I hand over the session to you.
Yeah. Thank you, Sahiti. Friends, as we all know, knowledge always increases by sharing. With this motto, I started this series at the time of the lockdown. So, by the grace of the God and the support of the stalwarts, this program is still doing very well. So, at this program, as all of you know, is strictly based on the purely academic discussions and what the problems we are getting in our daily practice. So, today we are having a very renowned stalwart, Dr. Anita Shyam, with us. Saiti, please show the introductory slide of the madam. Saiti, please read.
Yes, ma'am. It's my privilege to introduce Dr. Anita Shyam, ma'am. Ma'am is integrative psychologist, psychiatrist, sexual medicine specialist, clinical sexologist, and sex coach, intimacy and relationship coach. And ma'am has many awards and achievements to her credit. Ma'am is university topper and India's first female clinical sexologist and sex coach since 2002. And ma'am is privileged to be the India's first and only psychiatrist to write thesis on Hijra community and author and co-author of medical textbooks, national and international speaker, publications in national and international journals, member and fellow of national and international organizations. So I welcome you, ma'am.
So once again, please stop sharing. Once again, warm welcome, Dr. Anita. I know Dr. Anita's schedule is very busy and we are really honored to have you with us. I think you will definitely enjoy this program because we get the participants all across the geography and we get the questions also from all over. So once again, thank you so much because I heard Dr. Anita in some of the webinars. From that time, I was after her, ki please come in some of my webinar, but maybe due to her tight schedule, he was not able to join. So thank you once again. Warm welcome. See, Dr. MVP is joined from the Bhutan. A warm welcome, Dr. MVP. Warm welcome. Yeah, over to you, Dr. Anita.
Lovely. So, warm welcome from Dr. Shyam. I'm an integrative psychiatrist and I am talking from Boston. I know it's pretty warm in India right now, but it's pretty cold here, so I'm all jacket up. Thank you, Dr. Satwani, for thinking about me and for giving me this opportunity. Technology is amazing, Dr. Satwani, that we can connect with people all around the globe. And of course, Almighty has been great for giving me this opportunity for this knowledge, which I can share with you all. So
we are honored to have you with us.
Thanks so much, my dear. So I'm so glad you picked up this wonderful topic on desire disorder, something which is not talked about. And because of its diversity and multifactorial reasons, there's not much done on the treatment as well. So I'm glad this topic was picked and it's one of my favorite topics to speak on. So this is my screen sharing and thank you everybody who's been able to join this wonderful webinar. And today we're going to learn about sexual desire disorder. So this is the full screen. Wonderful. So this is me. They've already talked about me. So and I have no disclaimers for my presentation today. I'm strictly doing this presentation for Dr. Satwani for her webinars. Now let's understand what exactly is desire, what exactly is sexual dysfunction, and when do we call it as a dysfunction, right? So we all know that sexual desire is commonly defined as the subjective psychological state to initiate and maintain sexual behavior which is triggered by internal or external stimuli. right? We all are sexual beings. We are born with the sexual desire. And because of some internal and external stimuli, a desire is triggered, which leads to a lot of physiological, biological, emotional, plethora of factors which leads to a sexual functioning. And a complex network of direct effect and interaction among the biology, the psychology, the socio-cultural, spiritual, and sexual variable causes sexual functioning, causes a sexual activity. So talking about desire, we all talk about desire in terms of biology, talk about testosterone, talk about hormone estrogen, we talk, but desire is much more, right? It's much more than just hormones, than the biology acting up. It's a lot to do with the psychic of the person. It's a lot to do about the person itself, right? So the desire consists of three factors, the three main components. One component is definitely biology. There's a lot of biology which definitely plays for spontaneous desires, for spontaneous interests, for spontaneous sexual urges. But some of the main factors are cognitive component. What is this person's sexual beliefs? What are these person's sexual values, right? And again, there also has to be a motivation to be involved in sex, to have sex. And motivation has a lot to do about this person's emotion, the interpersonal factors and the relationship, okay? The desire to engage in that relationship, right? In the sexual activity. And that depends upon the quality of the relationship of the person or the sexual partners, right? So mainly remember, when you are dealing with desire issues, you're going to talk about three components. We talk about biology, and do not forget about the cognitive component and the motivation component. This is very important when we want to do some treatment for the patient. So we are not just strictly giving them pharmacological intervention. We are also giving them non-pharmacological intervention, which has the component and the motivation part as well, right? Now, low sexual desire may be a barometer of the emotional health of this relationship. So there are many a times you'll come across patients who have no problem with the biology. Their hormones are perfectly fine. And that's when you need to know there is something more to this person's sexual urge and desire, which is the emotional health of the relationship, also the cognitive component of this person, okay? And whether this person is really motivated to be involved in sexual activity with that partner, okay? So women may experience arousal, orgasm, and a satisfying sexual experience without even initiating it, or ever having a desire for sex as a distinct subjective experience. So this is a wonderful thing, and you need to know that women in general, there's not a lot of biology which works with women in terms of sexual desire or sexual urge, but there's much more when it comes to sex. So a female can indulge into a sexual act or a sexual behavior without even having the desire, without even having the arousal, or even when the person has not even thought about orgasm, because there's a lot of other factors which plays a very important role for women. Women have sex for various reasons. Because they want to be in that relationship. They are bonded with their partner. They have a very emotional connect. Sometimes people want to just keep this relationship, right? There has been a relationship issue, so just to keep on with the relationship, she might engage into a sexual act. Also, when we talk about women in general can initiate into sex even without the desire, is because the partner can absolutely stimulate, can cause a trigger in the women, and she can then indulge into a sexual act. So that is called as responsive desire, right? Somebody responses to a stimuli, responses to an arousal stimuli, and she then responds to get indulged into a sexual act. Now, there's another form of desire, which is called as a receptive desire, right? Even if the female is not interested, she has a busy schedule, she is very tired throughout the day. And such women can also indulge into a sexual act when there is enough stimuli, if there's enough stimulus initiation from the partner, and she then becomes receptive, right? Now she's not responsive. She's receiving those stimuli and then she responds. Okay. There's another type of desire, which is an adaptive desire. Okay. I had a patient long time ago, and she would never be interested in having sex with the partner. And we kind of digged into the history. We wanted to know what's going on. It's not hormones, it's not biology. Husband is, the relationship is really very nice. What had happened with this particular with particular women is that her husband would always drink. He would drink alcohol. Something which just put her off was the smell of alcohol, the way he behaved when he was taken in, when he was consuming alcohol, and then he would initiate sex. And that became her adaptive response. So she had an adaptive response as a negative response where she didn't want to get involved in sex. Once we changed that factor, her adaptive response became she would want to indulge into a sexual act with her husband. So these are there are three major components for desire. Whenever you're treating a patient, remember there are three components for desire and response. Is that desire comes in various forms of responses: responsive, receptive, and adaptive response. Okay, we all know what is a sexual response cycle, and I'll quickly take you over what exactly is. So, starting with Master and Johnson's, there was a very linear model where they categorize sex into desire, arousal, orgasm, resolution. But what Dr. Basin found is sex is not that easy, right? It's a very complex phenomenon, and this is called a non-linear model. So starting with a phase where somebody is absolutely neutral, there's no desire, there is no response, there is just nothing. This person is just having a wonderful day. But when from the state of neutrality, right, a sexual stimulus is given, that is when an arousal and desire can begin. Okay. This also cycle shows that there could be a spontaneous desire which could lead from a state of neutrality to a state of sexual stimulus, and there could be an arousal. Or spontaneous desire can just become a stimuli and trigger into an arousal, or spontaneous desire can trigger into a subjective arousal. Okay, and then this whole cycle, right? Desire, arousal cycle, it keeps on going on till the person reaches orgasm, right? And this says that there's a responsive, triggered desire and more arousal. With this circle hits into this phase, reaches a state of satisfaction, arousal. And depending on how this whole cycle went, that is when a female is motivated to indulge into a sexual act in future. So there's a lot of stress given to the various phases of sexual response cycles and the experience the women or the men have to get indulged into an act again. So this is an adaptive model for the sexual response cycle. And again, this is something very similar, but here they talk about the drive, which can initiate motivation, which can be a receptive sexual stimuli, which can lead to a lot of physiological, mental arousal, and that gives a state of orgasm. A positive response is orgasm, and depending on the experience and the reward received during an orgasm, the motivation is again built. Right? This is again the same. They talk about the spontaneous desire, sexual satisfaction, which leads to motivation. Okay. Now, sexual dysfunction is a difficulty or a challenge experienced by an individual or a couple during any stage of a normal sexual activity, including the physical pleasure, the desire, arousal, or orgasm. So any phase, there is an interruption, there is a challenge, there is some problem happening with any of these phases can affect the entire sexual response of a person. Okay. And when is it called a disorder? When this causes extreme distress to self and to this relationship, and it is affecting the individual's daily day-to-day functioning, the relationship and their sexual life. Now, there could be more than one sexual challenge or a problem at one time, and the prevalence is very high. 43% of women and 31% of men suffer from sexual dysfunction of some kind during their lifetime. Okay, and there are specifiers that sexual dysfunctions or sexual challenges can be lifelong. That means from the time this person has started having sex, he or she has always experienced sexual dysfunction, or it could be acquired during any stage of their life. They have suddenly started experiencing some type of sexual dysfunction. Or it can also be generalized. That means it is all the time present, every time during the functioning of this person on day-to-day life. Or it could be situational, and it could also be specific. Situational means the person has sexual dysfunction only on certain situations, right? If the in-laws have come to the house, right, the female doesn't feel like having sex, right? Or if there are certain situation like maybe she's very stressed out at work or at home, she doesn't want to have sex. Specific would be a man or a female can have sex with some other partner, but with this particular partner, there is a problem. So that is very specific, right? And this could be, there could be psychological factors, or it could be purely biological factors, or it could be a combination. So mostly you have to keep, this is a thumb rule. Not any sexual dysfunction could be just biological or hormonal or medical. There has to be always a component of psychological. That's why when we treat patients, we not only treat by hormones, by giving them some medication, we also treat the psychological and the relationship aspect. Okay, this is a classification of ICD-10 and DSM-5. DSM-5 is, they both are classification modules, and we strictly follow DSM-5 in India, but ICD-10 is also followed throughout India and the world. So we see the desire, like we have desire, arousal, pain, and other disorders. So it's the sexual response cycle they've classified, and you have nomenclatures. So male, hypoactive sexual desire disorder. Female, the whole thing is combined, the desire and arousal into sexual interest and arousal disorder. And so this is, also there is arousal where we talk about male erectile dysfunction, or male premature ejaculation, or delayed ejaculation will be a part of orgasmic disorder. But today we are just going to focus on this, that is sexual desire disorder, hypoactive in men, and sexual interest and arousal disorder in female. Okay, so what could be the etiological factors, right? So sexual dysfunction, as we said, is a complex interaction of the psychology, interpersonal, social, cultural, physiological, and gender influence process. Okay. So when I want you, there are 5 basic factors which lead to sexual dysfunction or any dysfunction in a person. So we talk about biology, of course, we talk about hormones, medical conditions. Then we talk about psychology, depression, anxiety, mood disorder, interpersonal problems. Then we have talked about social model. Social model is what negative influences this person has had. What does the society talk about sex? What does the society talk about this relationship, right? But there are other 2 factors we should not forget. So we talk about biopsychosocial model, but recently the sexual and the spiritual aspect has been added to this model. So what are we talking about? Spiritual, right? I used to have a patient who had sexual dysfunction because constantly she would keep on fasting because her spiritual connect was so strong. She was so ritualistic that she had Mondays for Shiv Bhagwan, Wednesday for some Bhagwan, and as a result her desire kept on lowering down, because this is what a spiritual aspect is. Some spiritual teaching also have a very, very negative connotation to sex or a physical intimacy, right? So there's a lot of spiritual script which is given throughout the person's life, which can affect the sexual functioning. Talk about sex, okay, the sexual factor. So as we just said, during a phase of a person, there could be not just one, there could be more sexual problems, and the sexual problems can be in the person or it could be in the partner, which is leading to sexual dysfunction in this person, right? So remember, when you intervene a person, when you are assessing a person, and also when you are helping this person with a treatment plan, you talk about the biopsychosocial, the spiritual, and the sexual model, and then it becomes very easy to treat and intervene such patients. Okay, here it is. Okay, we just talked about this. Okay, we talked about the sexual factors, right? And I just told you, like, it could be a lot of negative scripts, negative upbringing, negativity which is created around sex, masturbation, which could affect this person's sexual functioning, right? Also, there could be other sexual problems. What could be sexual problem? Many a time, men just come with erectile dysfunction, or they could have premature ejaculation, and we kind of try to stick to this issue, but we don't tackle issues of desire. We don't tackle issues of relationship, which is affecting this person's desire, which is leading to these problems, right? Secondly, also with females might have sexual like they could have desire problems, which could lead to painful sex or painful sex, which could affect their orgasm, right? So everything is so connected and not so linear that you have to think about what could be the main factor for this person. I come across patients a lot of time that they come and they say like, well, you know what, I don't feel like having sex, I just don't have this desire. Especially this particular patient recently I had, he mainly came because he is not attracted to his wife, right? And the wife, of course, has complained that he is not sexually connected with me. We don't have sexual intimacy. Taking a detailed history, we came across that he actually suffers with erectile dysfunction, which is affecting the desire, which is affecting their relationship and their wife. Right. And the wife also then gradually, as an adaptive response, her desire keeps on deteriorating because she's not getting sex from this person. Relationship factors are very, very important. They could be the independent factor for causing sexual dysfunction, right? It could affect the desire and the entire sexual response cycle. So there's a lot of dynamics which play between a couple, which can lead to sexual dysfunction, cause a lot of psychological stressors, which could lead to a lot of medical factors, which could in turn lead to sexual dysfunction, right? And many a time we forget the concept of desire discrepancy. So a lot of couples do come to me and say, Madam, I think my husband or my wife has high desire, or my husband or my wife has low desire. And truly there is no concept about high desire and low desire, right? There is always a concept of desire discrepancy. Somebody likes to have sex every day, whereas the partner doesn't like to have sex every day. Right? Somebody would want to have anal sex. Somebody said, no, I don't want to have anal sex. So these are all desire and preferences. But as a specialist, as a professional, it is our duty to clear these misconceptions in the patient and help them to reach a balanced goal, right? Which can be pleasurable for both the partners. So many a times I always try to give them a psychoeducation by saying, hey, let's not talk about, oh, he or she has more desire, I have less desire. Okay. So many a times our men, they are so strongly influenced by the cultural messages. Remember, we just talked about the cultural aspect where men are supposed to be masculine, always be up for having sex. They are always very erection centered, and rather than being desire centered, they're very erection centered. Penis is a big thing for a man. That's the masculinity. He is defined by the masculinity is defined by the penis in men, and that creates a lot of pressure, which causes a lot of dysfunction in a relationship, affecting the desire also. So here we say social pressure and expectation of gender role and masculine sexual script have been identified as a risk factor for sexual desire level, and stigmatization of reduced male libido might negatively influence the sexual satisfaction. Men may feel that they should constantly report high levels of sexual desire, even if it is not real, and they should be the gender pleasing their partner. Okay. So I think we all know what can affect sexual functioning, right? We all know age, hormones, androgen deficiency in men. And there's a big controversy if truly testosterone plays a very important role in the desire of men or it doesn't. And also the prolactin levels. So the main two hormones which you should really look into is testosterone and prolactin. Antidepressants, psychological factor, we talked depression, anxiety, mood disorders, schizophrenia, anything affects the sexual functioning, and even their treatment. Sadly, yes, the treatment do affect the sexual functioning as well. Anxiety conditions, for men and women nowadays, when they have become very conscious about their body and they're constantly on some type of supplements, diet, that also affects the sexual functioning. Cancer, cardiovascular problems, right? Metabolic problems like diabetes, obesity, they all affect the sexual functioning. Elevated dopamine level, epilepsy, HIV, hyperprolactinemia, infertility, psychologically, of course, post-traumatic stress disorder, prostate in men, prostatitis, pelvic pain syndromes, renal functioning, anything and everything can affect the sexual functioning of a person, right? Aging affects the testosterone level, slows down our body, slows down the metabolism, which affects the spontaneous desire in an individual. And it can also affect the sexual functioning overall. So this is, we just discussed about this. Now, psychological aspect of desire could be marital problems. We talk, there's less of compatibility. There's no emotional closeness or romanticism. Religiously, a lot of factors affect psychological factors like depression, anxiety, OCD. We just talked about all this. So all these psychological aspects affect the desire of a person. A quick brush through is what really happens when a female is suffering from hyperglycemia. It affects the vaginal flora, decreases lubrication, tract infection, causes burning, irritation, dryness, right? All these affect the person is in pain or discomfort and she doesn't want to have sex. Vascular complications, which affect the blood flow and the engrossment of the clitoris, the vaginal, the vulva area. If that is affected, desire is definitely not there because if the arousal is not as significant, which affects the desire. Various neuropathies and various hormonal problems can affect in women. We talked about psychology, depression, sociocultural aspect. So how do you evaluate? Now you have this nice knowledge about, oh, desire, this is desire, and this is what happens as factors. We investigate these individuals, right? There are various modules which are available: the Allow model, the Plicit model, and the Meaves model. So these models help you to evaluate like what could be happening with this individual. Like this, I'll just explain to you what is a Plicit model because this is very commonly used. Plicit models is you give permission to the patient that, hey, you know what, I would like to know about your sexual life. So you do ice-breaking questions like, so would you be interested in talking about your sexual life or your sexual health? How is your sexual life going? Okay, is everything well in your sexual relationship? So here you're opening yourself as a professional, giving them permission that, yes, I'm asking you a question because I'm willing to help you. I'm willing to listen to your questions and your concerns. Once the patient opens up, you give them limited information. Like if there's a desire issue, then you would give them information like, hey, this in your situation, due to this depression, anxiety, it could be affecting. You could give them some information to read, give them some literature work so that you're giving them limited information and telling them, yes, you know what, this is treatable. Please reach out to me or a professional for help. Specific suggestions would be, if a desire issue and with the history you get to know, it could be a relationship problem. Then you could say, you know what, maybe spend more intimate time with each other, try to get connected and try to understand each other's need. Specific suggestion. And intensive therapy is when you know that this person or this couple are going to need a lot of therapy. So this is a very commonly model, Plicit model, which is used. You evaluate the person, right? You give them guidance and then also direct them to therapy. Okay. Any evaluation, whether it is male or sexual functioning, dysfunctioning, we need to assess what are the predisposing factor, what is the precipitating factor, and what is maintaining this problem. You take a detailed history, right? This detailed sexual and relationship history is very important. Medical history, very, very important. Simple questions like, do you get backaches, right? Do you get backaches? And the female says, oh yeah, you know, I constantly have backache. And of course she has backache. She would not be interested in sex because that is affecting her entire functioning. Backache is a very common thing, right? We also take a detailed history about, is there any history of sexual abuse in the childhood, right? Any history of sexual abuse throughout her life, suffering from depression? Is there any alcohol, substance abuse? Okay. Any other factors, any bad experiences in life, a negative experience in life, which is affecting the sexual functioning. That is very important to evaluate when you do in history taking an assessment. This is a nice flow chart. When a person with sexual dysfunction comes to you, you as a treating doctor are going to take a lovely, nice history personal history, sexual history, relationship history, psychosocial history. And comprehensive medical history is also taken. You find the possible etiological factor. I always tell you, it's not just going to be medical or hormonal. There's always going to be a combination of psychological factors. Okay, so we always work in a combination. You talk to the patient, talk to the partner, do some basic sex education, certain guidance for treatment. Once you've done that, right, you then, if that is not your cup of tea, you refer the patient to a professional for medical and psychological treatment. So you are evaluating this person holistically. Okay. These are just list of predisposing, maintaining, and precipitating factor. So you could, whenever my slides will be with Dr. Ritu, and you can always have a look at these slides, right? As I said, we can always form our own personal interview or scales, but there are scales available also. Just let's move on. I know we are running short of time, but what are the various management? I know you guys are always interested. So as a professional, you want to improve their quality of life by creating a sex positive, open-minded, pleasure-based approach, which is very client-centered and a very goal-oriented, which is going to give you result. Remember, you giving suggestions to the patient is not going to help unless and until it is result-driven. They see results and then they think, oh, you know what, this professional, this doctor can help me. And always remember, do not bring your biases and your prejudice in your treatment, because you want to give a very sex-positive approach to this person, a very sex-positive overview of this problem to them. And always be open-minded. If you have some restrictions, some prejudice, your own biases, please do not bring it into your practices. I often get questions like, so ma'am, what do you think about relationship outside marriages? What do you think about polygamous relationship? And I am not here to judge, right? Even though if I'm not somebody who is open to such type of practices, or I have my own restriction, I'm not going to be judgmental. I would always say it is definitely preferential. It is what the couples or the individual with consent decide to have. Okay. Always remember your interventions have to be very target based. So if you know this female is suffering from dry vagina or dry vaginal flora, you give that suggestion that would help this person. If this patient is suffering from pain during sex and you have to target the pain problem, you treat the problem, which will help the patient in overall sexual functioning. If there is non-coital sexual pain disorder, right, you treat that problem. So whatever this problem is, if the patient has genital infections, if the patient has other problems, the result, right? Because you cannot just treat everything, treat what is just required, and you keep on building to that. So if the person has depression and patient is on antidepressants, so you talk to the psychiatrist to probably prescribe a medication which doesn't cause sexual dysfunction or causes lower sexual dysfunction. If the person is suffering from anxiety, depression, you treat that first so you can see changes, right? So you treat what is there, you have a very target-based approach. Very, very important. Sex therapy, any type of sexual dysfunction cannot be treated in a wand, right? In a swift. So I always tell my patients, see, I don't do magic. I practice science, and I would really appreciate if it's not going to be fixed in one day. So you go slow. And what do you mean by going low? Even if you have to prescribe any medication, you start with the lowest dose and then you build up. So sex therapy could be individual therapy and couples therapy, where there is a lot of experimental, exploratory, experiential, and enhancing techniques to use. Right? One of the very common techniques used are the masturbation protocols and communication skills, sexual communication skills. So remember, now when we talked about sexual desire and the component, this is the second component, which is the cognitive and the motivational. So if the couple do not have any sexual communication throughout the day, throughout the week, they don't have any communication with each other, they are not connected with each other, sex is not happening, right? So this is a form of sex therapy. We worked on the body images. focus your treatment on pleasure and satisfaction, not on the goal and not on penetration. We have a lot of cognitive behavioral therapy, mindfulness-based cognitive behavioral therapy, and if there is pain and arousal issues or aversion issues, then we have systematic desensitization as various other options which you could prescribe is various sex positions. We can give vaginal moisturizers, and a very important is, as professional, you advise sex toys and pleasure accessories. Okay, and mainly when we talk about connection, intimacy, we talk about communication. Remember, it's sometimes sex doesn't become spontaneous to a lot of people, and as the relationship becomes longer and longer, that is when you need to prioritize sexual intimacy. That's why keeping time aside, specifying the time, right? Couples would reserve time for connecting with each other one-on-one. If there's a very reserving time before exhaustion set, like, if the person is very tired or they know that they're going to have a very busy week, so setting aside, reserving time, we can creating a timetable. So in general, this is all called intimacy, connection, and sexual intimacy connection techniques. Okay, we talked about culture. We talked about like how important is relationship. Okay, there are various sex therapy modules which are available for practicing behavioral strengthening techniques, right? And in female, when you're dealing with a female specifically with low sexual desire, women do not engage in sexual relationship, sexual intimacy, or start having deterioration in their desire when they do not achieve orgasm. Like they do not know what pleasure is. So orgasm consistency training is important in female if they have low sexual desire. You train or you teach or you guide this couple, if they are having partner sex, how to basically have sexual pleasure. And once they keep on having pleasure, that's when they are interested in having a sexual intimacy relationship. So systemic desensitization is when patients suffer from pain or fear of penetration. That is when this works. This is a classic conditional response. I just discussed what is an orgasm consistent training. It's a cognitive behavioral intervention where you help the person have change the maladaptive cognitive thought process, bringing about a behavioral change. You guide them to have behavioral changes. Some of these techniques are, you can have direct masturbation, mutual masturbation, right? Or simultaneously you just self masturbation, but you're doing in the presence of a partner. Sensate focus techniques. This was by Master and Johnson's, a wonderful technique. It is worldwide, where there is more connection to the relationship, leaving aside penetration, more body to body, skin to skin, more of individual and couples connections. Parietal alignment exercises. People don't talk about what could be more pleasurable, not just sex position, but the alignment, right? Talk about compatibility. We need to have sexual coital compatibility also, which is very important. So drive induction techniques, which was by Bridle and Lopiloco. And these are again techniques which are used for enhancing, inducing drive or sexual urge. This is Master and Johnson's technique, the sensate focus. This is another technique. So there's a lot of techniques. These are pharmacological. If the female, we are running short of time, but pharmacological interventions are also available. For a lot of men who come with low sexual desire and a detailed history suggests that there could be a factor of erectile dysfunction or premature ejaculation, which could affect the desire. You treat that problem and you'll see the desire really comes back. So I have patients who are in long-term relationships and they suddenly have deteriorating desires. This could be because of andropause. So their sexual functioning is really becoming a challenge. Erection is becoming a challenge. So once you treat the erection or premature ejaculation, boom, the desire comes back. Same is with the female. If she's suffering from dryness, if she doesn't want to have sex because of relationship issue, you fix that, desire automatically comes back, right? So Let's see. So these are all medications which are used. Very, very important is lifestyle modification, right? Having a healthy diet, a routine exercise, of course, substances, smoking, alcohol, avoiding those factors are very important. Now, many a time we give them a lot of strategies, but we do not give them a lifestyle modification. One of the other important thing is, as a physician, as a sexual medicine practitioner, you can also guide them with different types of lifestyle techniques. What could that be? One of our patients, the couple they came to me with a problem that we just don't feel like having sex anymore. And my wife is never around. The wife says my husband is never available for sex. So realize they both have the same problem, like some sexual dysfunction, both of them. So after taking a detailed history, we realized that the female was always tired by the end of the day. The man, even if he was available at home, he couldn't have sex because he was living in a joint family. So this became a real problem. Like the wife had to be available for taking the house, taking care of the household chores, and there was no opportunity. So we guided them with a technique, right? What could be a good time when they could, come out of this joint family, go into their bedroom and have sex. And even so, those simple strategies change their sexual relationship, and then they were boom having sex again without really the wife getting too tired and still trying to find time in a joint family. So as I said, no treatment for sexual dysfunction could be one shot, could be one treatment. It is going to be multifactorial. You're going to focus on all the 5 aspects of treatment. Lastly, always talk to your patient about benefits of sex, how important it is for their physical health, their emotional, psychological health, and for their sexual relationship as well. Thank you for your patient listening. I know I took a lot of time, but it's just a topic which cannot be finished in like 20 minutes. So sorry, Dr. Satwani.
No problem, Dr. Anita. Very well, very well. You have covered all the things. Huge round of applause. Huh? And little correction. I am Dr. Santwani, not Satwani. Huh?
Santwani, sorry.
Yes.
Sorry, I
No
should rather
problem.
call you Dr. Ritu. Dr. Ritu
Yeah,
would be more.
whatever is
Yeah.
comfortable for you, madam. Huh? Thank you so much, madam. We have received some questions on the YouTube. With your permission, can I start taking the questions?
Absolutely. Let's do that.
Yeah. The first question is from Dr. Ashraf. He has joined from Dhaka. He's giving a very good remark. Excellent lecture. Madam has covered all the things. Dr. Ritu requesting you please invite such kind of more stalwarts in your program. See, sir. And his question is, Madam, will you please elaborate little bit more regarding the role of lifestyle for HSDD?
Yes. So, Mr. Ashraf, Dr. Ashraf, thank you for joining, and thank you for those kind remarks. Lifestyle modification becomes very important, especially if you talk about obesity, right? Obesity plays a very important role, and it can be a killer for desire in a lot of ways, like body image issues, acceptance of the body. Secondly, there's a lot of hurdle even on the physical aspect of sexuality. So things like being very active, because of course you want the blood circulation to be very nice. So healthy activity, mainly cardio exercises, brisk walking every day. Diet plays a very, very important role. You don't want patient to be suffering with the lifestyle problems like hypercholesterolemia, blood pressure, because they all affect. Even simple, remember, blood pressure, it could affect the blood supply to the genital organs. It could affect the arousal. And of course, it affects the desire, because there is no arousal, there's no desire, right? Other things is being very, very hydrated. Okay. Dehydration can also affect the overall arousal of a person. Lubrication is affected. So these are the basic lifestyle modifications. Micronutrients in your diet is very important. So I always advise my patients to at least have a handful of nuts, mixed nut, which can give you micronutrients, a lot of green leafy vegetables in your diet, and lots of fruits. I have treated a young male patient, 24-year-old, who was brought to me by his family for reduced suddenly drop in his desire, and we could change his entire sexual functioning by behavioral changes. We also advised him for sun exposure because vitamin D is becoming a big, big issue in sexual dysfunction. Things like these small things, diet, sleep, sun exposure, okay, and of course, good hydration. So these lifestyle changes can bring about a lot of changes in your patients.
Thank you, Madam Anita, because I think you have pointed out very well because vitamin D deficiency these days has come in the picture of the everything. So it's better to give the vitamin D. Of course, we are giving in every ailments, infertility, PCOS also we are giving. Yeah, thank you so much. We have received two comments here also. One is from Dr. Renu Bhatia, Madam. Madam is a stalwart from Kanpur, a very dear Madam, always joins all the program, and she is also a very knowledgeable doctor. Madam is giving the comment, excellent talk. Another comment from Dr. MBP. Thank you, Dr. Anita Shyam, for your beautiful insight on the trot for 40 minutes. So, congratulations once again, Dr. Anita. Yeah, there is another question I received from Dr. Thapa. Dr. Thapa has joined from Kathmandu, Nepal. He is writing, Madam, for the decreased desire in males, please suggest some good drugs.
Lovely and lovely, and I love Nepal. Oh my God, I've never visited, but I love Nepal someday. But this is what you could do. See, there's no fix. I don't think there's a fixed medication which can be given. But yes, a low dose of tadalafil, 2.5 milligrams daily after breakfast, it has shown to increase the desire in men and also help their arousal. That means even if they want to have spontaneous sex, it helps in getting erection very easily. So a low dose of tadalafil helps. Now, a lot of times men come to you and they will just talk about, okay, I don't feel like having sex and I'm being pestered by my partner to have sex. And when you take a detailed history, things like premature ejaculation could be a factor, erectile dysfunction could be a factor, and you then start treating them on those things, desire automatically comes up. Also, now if the female, right, the desire on one partner can be affected by a sexual dysfunction in the female. So you always inquire things like, so who initiates sex in your relationship? Things like, do both of you enjoy sex, right? And very important, $1 million questions will be two questions. Okay. What do you like about sex, or what does your partner like about sex? And what you do not like about sex, and what does your partner doesn't like? And that could give you clue even for the behavioral changes or the sexual changes in this treatment in this patient. So for you, if you come across a lot of patients who have low desire, do not just go deep into testosterone, because a lot of research says testosterone it does play a very important role in urges, sexual fantasies. But even if patients have the highest testosterone level, they might have low libido. Even patient with low testosterone can have wonderful sexual urges and desire. So they all depend on the cognitive scripts, the motivation factors, and the relationship factors. To tackle these aspects, start the patient on tadalafil 2.5 milligrams. If you want, increase it whenever the person is interested in whenever there is an encounter or sexual thing. Start a patient on sildenafil and duloxetine combination, which will help this person get spontaneous, nice erection. The couple will have wonderful sex, and I'm sure then the desire booms up. If you think testosterone is a factor, when there is a low testosterone, do a testosterone test. Start the patient on low dose testosterone. Check the prolactin levels. If the patient has hyperprolactinemia, there is a high possibility that the lack of sensation could be due to prolactin levels. Reduce the prolactin levels, and you will see a wonderful change in this patient.
Thank you, Madam. The another question is from Dr. Rehana Sheikh. She has joined from Bangalore. Her query, these days we are seeing the patients post using the sex toys. Some patients are coming to us that post using the sex toys, actually not very clear, post using the sex toys, the more incidence of HSDD they are seeing. So what's your comment on this?
Yes. So sexual toys, when used rightly, right, when they use in the right manner, they're used for enhancing sexual desire. They're used for enhancing the pleasure and the arousal, right? Now, when they're used in a wrong way, in a wrong technique, right, this can also cause reduce in their desire. Why does this happen? Mainly because if there's a constant use of these devices and there is no connection with their partner, that could affect. Secondly, if they are used in a not in the right technique, it can cause pain, right? It can cause severe pain that can affect their desire. Thirdly, a lot of women do not use lubricants. They assume that just using sex toys can stimulate them and they can get lubrication. So I always advise patients, try to use a personal lubricant when you're using these sex toys. But see, we are human beings. We always want a partner connection, even if it's not a monogamous relationship. But having a partner helps. If there is no partner, sex toys. In fact, I always advise bring pleasure accessories even in a relationship. It helps to enhance the pleasure. So having a partner is good. Not having a partner is also good. But using the pleasure accessories in the right way can certainly help uh, in the desire. So if the ask your patient if they have pain, how many times are they using the device. I had this patient, I think last week, and she uses a wand. She uses that wand at a very high vibration, right? And probably she's got herself conditioned to high stimulation or a high frequency of this vibrator. So unless and until she gets that high stimulation, she doesn't feel aroused. So we had to again do a behavioral technique with her where we could bring her to using the vibrator at a very low module. And also when she was with her partner, even a very little stimulation could help her get desire. So these small techniques can certainly help you. Guide your patient to use sex accessories in the right way.
Thank you. Thank you so much. One last question I'm taking. This is from Dr. Jadhav. He has joined from Thane. Uh, his yeah, his question is, Madam, please suggest some more about the diet for the low sexual desire.
So, Dr. Santwani just mentioned about, we talked about vitamin D. So, vitamin D plays a very, very important role in overall functioning of a person, right? So, people who have low vitamin D have low mood, body fatigue, right? And of course, that affects the desire. So, simple techniques like you could ask the patient, make sure you go for a walk every single day, and it's not a leisure walk, it's going to be a brisk walk. You can do jogging, cardiovascular exercises. So healthy, being very physically active is very important. Secondly, diet plays a very important role because diet gives you a lot of nutrients. So you advise these patients to take good, colorful, seasonal fruits, good green leafy vegetables because they have a lot of micronutrients, and adding nuts to it is very important. Now, see, if nutrition has not been your forte, you cannot just tell a patient, oh, go eat healthy, and the patient has no direction. So what does healthy mean to that person? Healthy means to this person that I can have pizza every day, because that's what it means, unless and until you guide this patient what is actually required. So I give them a proper regime. Like, so if you are a vegetarian, then you are going to involve salads, you're going to involve dal or lentils, you're going to involve carbs, you're going to involve a lot of protein. So it's a well balanced diet. Secondly, you don't take nuts and fruit together. You during the snack time, you take nuts as a snack, so it is not overlapping with your meal time, and you get the maximum absorption of the micronutrients. You also take fruits not with your meals. You take it as a snack where it is not again overlapping with their dinner, and it is a specific time to take snacks. So I give them a good regime. Secondly, I also tell them different techniques. So besides just lifestyle, you need a lot of communication and a lot of connection in that relationship. So we also give them strategies to, okay, so how about you or both, if you can have tea together, have snack together, so you spend more time, there is more relationship connection. Secondly, and I also give them strategies of how many times they should hug, because a lot of patients, they say, no, we don't hug anymore. Like, we never hug each other. We never touch each other. The only time we touch each other is when we are having sex. So you also guide them with some behavioral technique, like, please involve hugging with each other, just touching each other at times. So your skin and your body are connected, right? All the time. You have that emotional connect. Talk to each other, at least in the intimate way. Compliment each other, which we forget to do. So sex just boom starts happening, right? It's, of course, spontaneous sex happen, but it doesn't boom happen like the whole week has gone, you've been fighting and sex happens on Saturday. It doesn't happen. So it's a process being created with a lot of behavioral changes. So you have physically active, right? A lot of techniques where you're emotionally healthy, lot of psychological connection happen, and then sex happens in these patients.
Thank you, madam. Dr. Poonam, if you want, you can unmute yourself and can ask the question. This is the last question. We have to wind up.
I want many patients complaint of loss of libido,
Mhm.
usually in 40 to 45 year age. How should we counsel them?
Yes. So 40 to 45-year age is a very, very tricky age group, Dr. Gupta. So in these patients, you definitely psychoeducate them that how hormones play a very important role, right? This is a time when the hormones, estrogen starts deteriorating, and this is also a time where we are more busy with the family. So even as a role of this patient, the role has become so intense with the children education, going to college. All these factors play a very important role in low desire. So you psychoeducate them, give them a good understanding of what could be the reasons the desire has been affected. You then also guide them about the loss of connection between the partners. If that is what is happening, they're drifting apart. You psychoeducate why being connected with each other emotionally is very important for their sexual functioning. Then very, very important strategy is, come on, let's do it. So what do you do as a professional? You guide them that, like any other instinct in a human's life, any other instinct, food, if you don't eat regularly, your diet goes down, right? If you don't drink water regularly, you don't feel thirsty anymore. Like any instinct, you sit for a long time, you get adjusted to sitting lifestyle. So you guide them that if sex is not becoming a priority, or you don't bring sex in your life, there is a high chance that you will keep on drifting apart, and this will not happen. So you also educate them why it is important to have sex regularly. Physiologically it is important, right? Physically it is important. If the female, you guide them to have to use lubricant, proper arousal technique. Sex is not all about penetration, so you guide them that, oh, you need to spend more time in foreplay, so there's a proper arousal. Secondly, use lubricants. Thirdly, bring sex in your life, make sex as a priority. So you give them a sex schedule. Like, if you think weeks are very busy for you, then maybe weekend, but make sure sex is a priority like any other instinct in you. If you do not, you might lose it. So educating your patients very honestly is very important.
Very true, very beautifully explained, Dr. Anita. Dr. Poonam is a very dear friend. She joined from the Varanasi. So, as you have very rightly pointed out, yeah, hi, Dr. Poonam. Good evening. Good evening.
Good evening.
Yeah, she is also very, very much always interested in the academic platforms. So, really happy to see you, Dr. Poonam.
Thank you.
Uh,
Thank you.
yeah. Dr. Anita, as you have rightly mentioned, yes, lot of patients these days are coming with like that. Madam, because once I treating the infertility, once we tell, yes, you have, how many times you are mating? No, it's hardly once in a month or twice in a month. That too also they are not mating in the ovulation days. Then how come the pregnancy happens? So very rightly you have pointed out. Due to paucity of the time, sorry, I have to wind up. A very interesting lecture. Thank you. Thank you once again from the bottom of my heart. And thank you, dear
Right.
friends. Yeah. Thank you, dear
Right.
friends who all have joined all across the geography. And friends, this coming Monday, we are not having a session due to Holi. And so I am planning to have the another webinar on Friday. I think Friday is 22nd. I will put the details. Those who are interested to know a little bit about the more about the thin endometrium, how to manage, I will be speaking on that on 21st around 4 p.m. So I will put the links. Do join, do log in. Thank you once again, Dr. Anita. Thank you, dear Sahiti. Thank you, Shield Pharma, for providing
Thank
the
you, Dr.
platform.
Thank you, Dr. Ritu.
Thank you, ma'am.